Others will join us as we go. My name is Shiva. I'm going to be the moderator this afternoon. I'm sort of standing in for some senior WHO colleagues who couldn't be here, unfortunately. Apologies from Dr. Tedros, the Director General, and the Chief of Cabinet, Dr. Schmidt, because they are busy with a discussion on the Ebola emergency crisis. And also good wishes from Edward Kelly, Head of Department of Health Systems, who is unfortunately on his way to Astana, where, as you know, a major primary health care conference is supposed to be held tomorrow. Today we are having a Global Health History Seminar 112. The title is Faith in Universal Health Coverage and Primary Health Care at 40 and the World Council of Churches at 70. My task is to introduce the subject, say a few words on primary health care, introduce the speakers, and also the Global Health History Center. And then last, maybe when we have a discussion, I will say a little bit about myself as we moderate the discussion afterwards. So I'll have 5 minutes to start off, and then the speakers on our side here, both Ben and Moy, will have 20 minutes, and then we'll have a discussion which should be about half an hour, and that's where the most active part should be. Many of you who might know primary health care, or who are here because of primary health care and universal health coverage, today, historically, the World Council of Churches and WHO are 70 years. And the primary health care anniversary is being celebrated next week in Astana, Kazakhstan. And primary health care will be 40 years. Maybe next week can become another living new history of primary health care too for the next 40 years as we chart the way forward. You might all remember the great success of the post-World War II in 1947 were not just the scientific and technological discovery of public health insecticides such as DDT, new drugs for TB, malaria, new diagnostics and microscopes, but most important success was the lessons learned after war, the post-war euphoria and demand and feeling of peace and the demand for more peace, and the need for reconstruction of war-damaged Europe and integrating the refugees and displaced people throughout Europe with more and more social justice and solidarity. That was the foundation of primary health care in post-1948, and the great global public health historical success by WHO, its member states, and the World Council of Churches in launching Alma Ata Primary Healthcare Declaration in 1978 in the Soviet Union and the Health for All 2000 campaign. This was what launched national health services and systems in Europe and also the drive for healthcare throughout the world. The success continued till beginning of Glasnost and the fall of Berlin Wall and end of the Cold War in 1989. A few words on the Global Health Histories WHO Center for Global Health Histories in York University. It was established in 2004, taking forward analysis and publications on historical development in national, regional, and global public health to provide a learning platform for health and multi-sectoral policies and development as we learn about the past forces which affected social, political, economic, and the future trends. My task here now is to introduce the speakers for this session of Global Health Histories. Today we have two speakers who will talk about the future of religion and health and healing, the past and the future, and the relationships between WHO and WCC. Ben Walker, a historian and theologian from York University, the ancient capital of England, and Dr. Mwai Makoka, a medical doctor and ecumenist from the warm heart of Africa, Malawi. Ben Walker completed his undergraduate and postgraduate training in history and African studies at the University of Cambridge and University of York, supported by the Wellcome Trust, the Center for Global Health Histories, a WHO collaborating center. Ben's specialty is the history of faith-based organizations, development and medical missions, and global health, with a particular focus on Ghana. He has path-breaking history of the relationship between global health and medical missions between 1919 and 1983, a very powerful historical perspective which sets some of the foundations for primary health care. He is currently a teaching fellow in African history at the University of York, and from November, he is also becoming the associate team leader for the Church of England's new large-scale project, Generous Churches Making and Nurturing Disciples across the Diocese of York. My pleasure to introduce Ben Walker, who will be the first speaker.
Thank you very much, Shiva. The World Council of Churches has a long-standing relationship with the World Health Organization. And if we're going to ensure that primary healthcare and universal healthcare are delivered as well and as fully as possible, this relationship needs to thrive. Too long has the WCC remained quiet in fulfilling its commitment to health as wholeness, to bringing the love of Christ to the whole person and not part of them alone. In the 1980s, this relationship, against the run of play, against prevailing international trends, managed to produce pilot projects, surveys, assessments of national health infrastructure, funding for seed awards, Christian health associations most famously, and even the building of hospitals. Yet, in 1990, the relationship between the two parties began to struggle. The success and drive of the prior decade, especially in primary healthcare, was pushed aside in favour of pharmaceutical delivery alone, socially unequal healthcare agendas, and programmes of disease prevention. This year, as the standing committees are being reawakened and the power of the collaboration between two giants of global health is begun to be restored. But for that relationship to flourish, and flourish it must, requires a keen understanding of how it grew in the past, when were its highlights, and when were its tribulations. As it's hard to miss, we're in the 40th anniversary year of primary healthcare, as well as the 70th of the WHO and WCC. It is high time that these decades be reassessed, so that as we go forward together, initiatives and fresh partnerships can be started on a clear and considered footing. One of the key aspects of this reassessment is analysing how the Christian Medical Commission of the WCC operated, how it reshaped international health organisations' work, and how it was influential in the creation of primary healthcare. Faith cannot be ignored in global health if we are to take seriously stakeholders, communities, national governments' values, and the foundations, the why, WHY, of healthcare itself. A narrative of development and subsequent disappointment has marked the history of the post-colonial world. The hope and triumphalism of the early years after independence, giving way to the corruption and poverty of the 70s and 80s, followed by structural adjustment and neoliberal reform. The history of global health, too, has been structured by this narrative. Ruth Prince has argued that interventions in the 1970s focused on emergencies, and African states retreated from the health for all goals that they pursued in the 60s and 70s. Primary health care, according to Prince, was short-lived after the Alma Ata Declaration in 1978. Kelly Lee ties these setbacks for primary health care to neoliberalism and to the power of the World Bank even, arguing that they ensured greater restrictions on public health spending. Moreover, she argues that primary health care was very quickly out of step with the priorities of major donors such as the United States, which wanted to focus on major diseases such as tuberculosis. Marcus Cueto has further shown how primary health care was left behind for the less broad and idealistic selective primary health care, with the Rockefeller Foundation identifying more cost-effective health strategies as early as 1979. And as most of us know, this was backed by UNICEF after 1980 under the leadership of James Grant. And as most of us know, these things played out over the 80s. Yet, what has been forgotten is that in spite of this retrenchment in international health, the transition to primary healthcare within medical mission development work and within the World Council of Churches and the Christian Medical Commission continued well beyond Alma Ata into at least the mid-1980s, actually right up to the 1990s. The relationship between mission and development had been reconstructed for them. In the 60s and 70s, Christians in international health were offering new models of how to perform older missionary ideals. Long-term medical missionary visions of human development were being reformulated and critiqued in the Christian Medical Commission, and they offered an alternative to older forms of medical missionary practice, such as hospital construction, that was particularly prolific in the 50s. So throughout the 1980s, the World Health Organization continued to link into these movements with the Christian Medical Commission and with medical mission primary healthcare. This provided a forum in which the WHO Director General at the time, Halfdan Mahler, could continue his campaign for a holistic vision for primary healthcare. And this, again, all in the face of prevailing winds of retreat and Mahler's loss of support of the WHO bureaucracy. With the CMC and with missionaries, Mahler's vision for the original primary healthcare continued to be promoted, not just in Geneva, but around the world. So primary healthcare, as most of us know, emerged from the concern in the second half of the 60s in the wake of the struggles with malaria eradication in the WHO and UNICEF to support national health systems rather than focus on disease eradication alone. In the 70s, there were attempts by WHO to pin it down. It had centuries-old connotations of community care and preventative work, but they wanted to use it as a rallying cry for equity. Socialist medicine, Chinese barefoot doctors, these are contextual examples emerging when the Declaration asserted that health was a human right, which had social determinants and was the responsibility of governments, and not for merely the absence of disease or infirmity. The Christian Medical Commission and its institutions that were produced after this, the Christian Health Associations, and medical missions across denominations, were part of this creation, formation and sustaining of the primary healthcare movement. Through the Christian Medical Commission and primary healthcare, medical missionaries themselves on the ground, in particular contexts all across the world, reformulated conceptions of human development, medicine and community. And this had long-term effect. The CMC had been meeting across the world since the mid-1960s, discussing how medical mission was going to change in the light of the end of colonialism and in the light of the significance of ecumenism. The CMC and the German Medical Institution in Tübingen, founded by the Basel Mission between the 60s and 80s, became the main setting for the debate about how Christian medicine was going to reform. It drew in theologians, doctors, ministers, who wanted to discuss how to imagine, survey and advise a huge amount of mission hospitals that were having to adapt to the end of empire. The CMC then managed to set up many pilot projects and surveys in coordination with WHO, particularly with primary healthcare. At the time, across the 60s, 70s and 80s, there was much cross-pollination between WHO and the CMC. The Nigerian Deputy Director of WHO, Tom Lambo, was a founding member, a part of the first meetings of the CMC in the late 60s. Within the context of the CMC, Christian concepts of human development were being changed and reimagined. There were people across denominations involved, as various as the Russian Orthodox theologian Metropolitan Anthony Bloom, the Anglican Bishop David Jenkins. Catholics, though not heavily involved in the early days, had representatives to the first commission meeting in 1968, who were sent through the relationships built with SEDOS. Through discussions, the Christian Medical Commission's main innovation became that the value of holistic approach to healthcare meant that the community itself could have healing properties, and that too much attention on hospital provision by past missions missed this vital element of the expression of the Christian gospel. A key part of the Christian Medical Commission's early aims was to break the boundary between formal medical mission practice and the life of the church community. But they managed to go even further. And in attempting to redefine the social units available for biomedical mission, they produced new ideas that came to function in primary healthcare as central. The Finnish medical missionary Håkan Hellberg put it in a CMC meeting around 1967 that the modern hospital, supported by a functioning society with laws and regulations, transport and hygiene and health control, is like the apex of a pyramid. It depends on the underlying structures. But, he argued, if we export this highly developed system with curing abilities to a country without underlying structures, the hospital becomes more or less a distorted sign of God's healing power. He was arguing within the CMC that Christian medicine had to move beyond the ways it had been conceived of socially. To confine it to the hospital, and even with greater contact with non-medically trained church communities, was to distort the sign of God's healing power. God's healing was attained commonly in institutions such as hospitals, which were inaccessible to most people, and the CMC was arguing that this had to change. And this said much about the sign of salvation which medical missions could offer. Christian medicine required understanding that communities already in a given area could produce healing. The biomedical dream of cure had to be enriched, they were arguing in these early days. That Christian medicine had to encompass both the having and the not having, the now and not yet, the tensions of Christian healing. And this meant going beyond the flock and beyond the hospital. As the American Lutheran minister Martin H. Schallemann put it in the CMC, this did not mean to exclude technological advancement, which he urged was a contribution to human health and could be viewed as a kind of endowment intending us to participate with the communion of saints in anticipating and preparing eternity. But it did mean reimagining how societies and cultures could live in dynamic relation to technological intervention. Inbuilt into the Christian Medical Commission dialogue about development was the importance of community-level healthcare from the bottom up. And this was more than ensuring simply that an individual patient had companionship. This was the idea that local communities had belonging, which could be centrally important to the healing of the whole person. As C.G. Harding puts it in another CMC debate in the early days, church groups could actually better attend to those feelings of belonging, and that as a result, minor disorders might actually disappear as a result of the loss of loneliness. Now, in order to judge what these communities could be, especially in a complex world full of porous borders and changing ideologies, meant that actually sociology became as important as medical science to the CMC. What was interpreted as a just community required anthropology alongside biblical insight. As Ian Ramsey, an Anglican bishop, put it in one of the CMC debates in the late 60s, the saving work of Christ must be contextualized, and the deliverance experience of the hospital must symbolize salvation in every situation. So, for the Christian Medical Commission, primary health care became the embodiment of a new way of conceiving what medical mission and human development could mean. In The Quest for Wholeness, which is the CMC's most significant publication in 1981, their way of viewing and practicing community health was emphasized as their greatest legacy worldwide. They summarized it like this: while the church had emphasized personal salvation, it was now coming to recognize that the uniqueness of the individual most frequently lay in his relationships in community. So there was a need to recapture the Hebraic concept of corporate salvation and the Pauline version of the new community of Christ. As they put it, solutions must always be developed within local concepts. Again, the bottom-up approach to healthcare. By this point, by the late 70s, Catholics were closely involved in these ideas. The CMC had Margaret Marquardt as central at this point. She was part of the advisory study group and was later named as the representative of the Pontifical Council Cor Unum of the Vatican to the CMC. As Socrates Litzios has argued, and some of you might know, these Christian Medical Commission ideas directly influenced the WHO's primary healthcare movement. Around this point, around the late 70s and early 80s, Marlow was even requiring WHO staff to read particular editions of the CMC's magazine Contact. Matthew Basagal-Braley also emphasises that CMC had major influence on the development of primary healthcare at this point. As a statement prepared for the Alma Ata conference for WHO and UNICEF, and by a group of non-governmental organisations which included the CMC, put it in 1978, non-governmental organisations support the view that the promotion of primary healthcare must be closely tied to a concern for total human development, the totality of human development, a holistic view of health, which encompasses physical, mental, social and spiritual well-being. This integrated approach to human development embodied a concern for the people rather than merely economic growth. So between the 60s and 70s, leading up to Alma Ata, medical missionaries were having an active role within and alongside international organisations. As Litzios shows further in his article on the CMC, from the earliest days of the primary healthcare movement in WHO, the CMC was closely involved. In some sense, they were originators. In the background document by Kenneth Newell on Health by the People is a comprehensive document which goes through different places in which primary healthcare was emerging in pilot projects. One of the key ones was in Jacquard in India, which was financed by the Christian Medical Commission. And not only that, but the Christian Medical Commission was also setting up ecumenical health organisations, such as in Ghana, the Christian Health Association of Ghana, CHAG. And these were considered in the early days to be directly tied to visions for primary healthcare. Both Catholics and Protestants were involved in CHAG from its outset. CHAG was originally an ecumenical organisation designed to enable medical missions some cooperation across denominational lines. It could form a sort of single lobbying power to formalise relations with governments. And its establishment was aided by the CMC, who aimed to spread these initiatives right across sub-Saharan Africa. CHAG, with the Catholic Secretariat in Ghana, was effective at brokering deals in the early days with governments, such as around hospital staff pay. It was also funded not only by 40 to 50% of its cost by the Ministry of Health, but also by the Dutch organisation MIMISA, the Miserior, the German Catholic organisation, the Canadian International Development Agency, and Christian Aid. It was able to further institutionalise and give direction to medical missionary voluntarism and across the sector in Ghana. As those who've studied it most, Woden, Olivier and Dimmock argue, this ensured missions could be represented and negotiate together as a group. As it was put in the CMC-led Tubinga meeting in '67 in Legon, CHAG aimed to, and I quote, coordinate all church-related medical programs, both Catholic and Protestant, and represent a united voice in negotiations with government. It was arguing that churches should explore new avenues of service in community health as distinct from the individualistic approach through curative medicine as practiced in hospitals. The CMC debates, the kind of language that you were getting in the CMC in the late 60s, was emerging directly in the formation of CHAG. And crucially, this meant that CHAG could encourage norms of community and social health that CMC was promoting, such as primary healthcare. By 1985, CHAG had within it 14 primary healthcare projects related to its institutions. 1984, it was arguing that Essential Drugs List, one of the key initiatives, was directly related to the need to ensure that primary healthcare functioned effectively. In 1983, CHAG argued that since primary healthcare ultimately has to serve 70% of Ghana, it should become a strong ecumenical activity with a separate department. CHAG, with its primary healthcare work, was aiming to advance spiritual and pastoral care for personnel and patients in the kind of terms that the CMC was forming. Through CHAG and through these initiatives, in the 70s and 80s onwards, amidst turmoil in Ghana, missionaries were actually expanding primary healthcare programs, again in spite of international retrenchment, in spite of the US going in a different direction, the World Bank going in a different direction. Medical missionaries on the ground in Ghana and church hospitals were able to practice primary healthcare throughout the 80s. This was in seminars, training programs, new projects, particularly Catholic medical mission, which by 1983 comprised 69% of CHAG. They were producing primary healthcare intensely. It was bubbling up everywhere. Contrary to what Marcus Cueto has argued for Latin America, in Ghana, by 1982, medical missions were growing primary healthcare, not retracting it. The Catholic Health institutions in 1982 provided mobile clinics, immunization, preventative health work, family planning advice, nutritional support, traveling nurses, community health teaching, and village work. PHC was a part of all of this. In Catholic records themselves, in 1982, St. Martin's Hospital, Agriesum, described primary health care it did in surrounding villages as its key programs for the next 5 years. At ABS, forgive me if I'm pronouncing that incorrectly, in the Sunyani diocese, there was usual clinic activities with traditional birth attendants and village health worker teaching, as well as family planning advice. From this, there was a plan to extend primary health care from the early 1980s right to the end, for villages to have primary health care within 10, 20 kilometres of hospitals. Now, it wasn't always perfect. There was issues with isolation, personnel, water problems, transportation, economic crisis. But outside of the visible centres of power, where primary healthcare was supposedly not working, in smaller organisations, it was alive and well. But also, in the WHO Standing Committee with the CMC, and this is where I'll begin to finish, primary healthcare was agreed to be studied from 1981 across the world. It started in Zimbabwe. Then in 1982, there's another standing committee meeting in which they discussed Southern Africa, the Andean countries, Anglophone West Africa. A former CMC member, with Hakan Helberg attending as a representative, noted that there were pilot projects starting. In 1984, the WHO and CMC Standing Committee on Primary Healthcare agreed there would be immunisation efforts, pharmaceutical programs, and in India, guinea worm reduction. Now, these initiatives might not seem like the hallmarks of primary healthcare, but as far as 1986, they were closely aligned together. WHO and CMC were jointly funding seed money, possibly even with the World Bank and UNDP, country projects in Sierra Leone, the Marshall Islands, Togo and Guinea-Bissau, amongst others, with district-level committees consisting of church, government and WHO representatives. They were going with it. In a joint statement with Halfdan Mahler in 1986, the CMC and WHO emphasised the ongoing commitment to health for all as a basic human right, and I quote, embodied in the promotion and support of health systems based on primary health care. This was followed up by a commitment to a framework for review, including joint government WHO and CMC teams. In Ghana, they even funded and developed a hospital called Nazareth with 14 surrounding clinics which combined spiritual, social and physical healing, elaborating primary health care in a specific context. The spiritual aspects of health and wholeness were emphasised within this context, and as WHO representatives put it, they admitted they were well able to make technical statements, but often they were trying to tackle the problem with the wrong tool. It was felt, and I quote again, that the CMC might have the right tool, and that care, rather than intervention, coping with suffering and dying, and spiritual healing were more essential. Now, primary healthcare, I conclude with this, was by no means perfect. We all know that. There was conflict, failures, overall structural inequalities that persisted in spite of consistent, powerful effort on behalf of the medical missions in Chad and Ghana. Nevertheless, there were great changes. It revolutionized the way in which healthcare has been structured and how it reached peoples who had average journeys to hospitals that could be 18 miles or longer over flooded rivers and across punishing savannas. This worked because it utilized large-scale medical mission systems that had been growing since the 1920s and had become formalized across British and French colonial Africa in the 50s. Still today, according to a recent Lancet article, 42% of the National Faith-Based Health Network National Faith-Based Health Network comprises 42% of Ghanaian healthcare, 40% in Kenya too, and large percentages across sub-Saharan Africa. In places where missionary healthcare missionary healthcare was built from the 20s onwards, there is long-term legacies for health infrastructure. And the CMC's radical alteration, the medical status quo, has had long-term beneficial impact. Today, survey work by the CMC, the analysis and path-breaking healthcare models should not be dismissed as a vestige of some earlier time, but a forerunner of best practice now. Now, much work is still to be done, we all know that. But as new collaborations between WHO and CMC and the WCC are being formed, we have to have the context of a close reading of how these relationships functioned at their best in the past, so we don't repeat mistakes, and so we don't ignore repeatable successes. Thank you very much.
Thank you very much, Ben, for a very inspiring talk on, and you have taken us very far back in the 60s to the formation of the Christian Medical Commission right here in this building, and also how that built into the relationship between the World Council of Churches and the cross down there with the World Health Organization, and the big influence on primary health care. Again, you have repeatedly reminded us that the whole principle of the Christian Medical Commission, the reform of medical missionaries, more towards from hospitals to holistic care and community care, I think is a very fundamental and very relevant even today. I think that was very, very critical. And then you have also taken us to the level of, at a country level, what happened from ecumenical organizations on health, which were formed by the support of the Christian Medical Commission and WHO taking this forward. And a good example was Ghana, and other examples in other parts of the world. I think you have really very rich, and also to how this holistic learning is very important so that we go forward. Thank you, Ben. Now my task is to introduce the next speaker. It's Mwai Makoka. Mwai is a medical doctor with undergraduate and postgraduate in medicine and public health, microbiology and infectious diseases in the University of Malawi and University of North Carolina, Chapel Hill, USA. He has worked in the University of Malawi Medical School, Malawi Ministry of Health and National AIDS Commission, and was also the executive director for the Christian Health Association of Malawi. He serves on the boards of the African Christian Health Association platform. The chairman is here, and also the Ecumenical Pharmaceutical Network and the Christian Connections for International Health. So the network, which was originally established in the 60s, is still active today and expanding. Mwai today is currently the lead in program on health and healing in WCC, supporting international ecumenical health work and expanding and scaling up the work of all churches in health and healing, and mobilizing WHO and other health and developmental organizations in prioritizing collaboration and investment in churches and faith-based organizations. Mwai?
Thank you very much, and I will pick up from where Ben, the previous presenter, has left off. And of course, there will be a little more overlap in terms of the time periods that we are covering. Let me just also acknowledge that we have the current executive director for the Christian Health Association of Ghana has joined us. So welcome again. And we also have the Deputy General Secretary of World Council of Churches. She's also with us. Thank you very much for joining us. I'm going to go through my presentation chronologically. So I'll look at the first 2 decades and so forth up to the era of Millennium Development Goals and the Sustainable Development Goals. Suffice to say that 1948 was a very busy year. What really concerns us immediately now is that the Universal Declaration of Human Rights was enacted in 1948. And it was riding on that where health is also constituted in the Constitution of WHO, that health is also one of the fundamental human rights. And we are jointly also celebrating the 70th anniversary with the World Health Organization. Since the establishment of the World Council of Churches, the first 2 decades, 48 to 68, there were some key developments, but from the onset, the World Council of Churches has been active in health, supporting medical work of the member churches, picking up work of the medical missionaries and so forth. And surveys and assessments were conducted to understand needs on the ground and to determine the best way to support churches to carry out their health work. And these assessments were not restricted to churches. These assessments involved supporting ministries of health in several countries. This period, you will recognize that includes the period where many countries were gaining independence and they were establishing their ministries of health. So the work of the World Council of Churches involved strengthening the ministries of health. In my own country, there is record actually that a team from World Council of Churches actually met the new president, Dr. Hastings Kamuzubana. We got independence in 1966. And the team went there, they met with him. And that was really the level of engagement. And the establishment of national Christian health associations were already started in that period. And somebody mentioned that actually establishment of national health associations had a healing influence on the competition that was prevailing around that time. And then 1962, there was the conference. The Lutheran World Federation and the World Council of Churches launched a study of medical missionary questions. And they set up a small team, a small task force to do the technical preparations from 1962. So between 62 and 64 was a preparatory period. And the consultation was held in 64, hosted by the German Institute of Medical Mission. And the theme was the healing church. And there is the publication of the report. And the healing church reviewed the prevailing and the future role of the church in health and healing. The Christian ministry of healing belongs to the congregation as a whole, and only in that context to those who are specially trained. So this was the feeling, these were the decisions, when they looked at the future and the current work of churches, they say, actually, the work of health and healing, it doesn't only belong to the specialized, to nurses and doctors. Primarily belongs to the whole congregation. And only in that context do trained health workers become like sent from the congregation to work on health and healing. And then they also said at the local level, they had already seen that the medical mission work and the life of the congregation were actually traveling different paths. So these were very strong concerns, and they also mentioned that actually the programs that are being introduced that are run in the churches must reasonably be expected to become an integral part of the life and witness of the local church. These are contained in this little booklet. Between 64, they were continuing conversations, and then they decided to have a second meeting in 67. And 67, the main concerns were theological and practical implications of the new understanding of health and healing, and the need for a closer collaboration between the disciplines of medicine and theology. These were 1967. And then you see that after 67, there's a little more formal engagements, formal studies that the commission was engaged in. During that time, these discussions in Tübingen had made a recommendation to World Council of Churches to establish a commission. And the Central Committee met in Greece in August 67, and decided that actually WCC should establish a commission. And the General Assembly in Uppsala 1968 ratified that decision, and the Christian Medical Commission was formally established in 1968, mainly for two purposes. Firstly, coordination. By that time, there were over 2,000 hospitals. Running costs were rising. Governments that were newly emerging started establishing similar facilities. And there was need for joint planning and collective negotiations with governments. And also theological reflection to answer the question, what's the unique contribution to health and medical services that the churches would offer? And the concern was that actually the churches were not simply service agency or foreign aid programs. They needed to be clear what is their unique role as churches working on health. So these concerns were the overall goals of the commission. And they held their first meeting in September 1968. And they discussed as their goal to accompany and help coordinate the health and healing ministries of the member churches. And they set out 3 objectives. Number 1, to help churches in their search for a Christian understanding of health and healing. Secondly, to promote innovative approaches to health care. And thirdly, to encourage church-related health programs to collaborate with each other. And even from the previous presentation, you can see how these 3 objectives were actually achieved in the work of the Christian Medical Commission. And at this first meeting, they already decided to seek an official relationship with the World Health Organization. The third decade, from 68 to 78, we see that the commission now getting in full operation, asking difficult questions from observations on the ground. They noted that over 95% of church-related health activities were actually curative and were based on Western models. And part of the observation is that even in areas that were saved by mission hospitals for many years, the health status of people near the church, around the hospital, the health status was not better than those that are very far away from the hospital. So they say something must be wrong. There has to be a problem with what they're doing. And the other questions were like, yeah, but our hospital has a catchment population of 100,000 people, and you have 1 or 2 doctors there. How can a hospital, how can a doctor, how can a health system be responsible for 100,000 people? What does that mean? How can you go about it? Then they started experimenting with alternative models of healthcare. And these were picked up in the 2 publications by World Health Organization and UNICEF in 1975. On the part of coordination, we see that the Commission continued with the establishment, supporting national councils of churches, national structures to establish associations. And then they picked up a notch higher by bringing together coordinators from across Africa. And they had their first meeting in 1970. And then they had another meeting, and they had this. So this report was actually for the third meeting for the coordinators of mission health facilities in Africa. And this work has continued, having meetings every 2 years up to now. And this has now grown into what's called the Africa Christian Health Associations platform. That is still meeting every 2 years. And the next meeting is next year in Yaoundé, Cameroon. So these are seeds that are really persisting, and they're very sustainable. The other issue, the other development was actually from December 1970, the Commission started publishing the Contact magazine. And the Contact reached all levels, from policy to grassroots. It publicized the resolutions of the World Health Assembly There are only a few people who can come to the assembly. And the formal dissemination of resolutions had its own limitations. The contact was picking up key resolutions from the assembly and publicizing them to the grassroots. And also publicizing WHO publications. And they promoted, of course, primary health care. And it became what was called a hospital without walls. Here you see one of the issues people were struggle with is isolation. You are working in a rural hospital, you are all by yourself. You get mail once every 2 months. And this sense of isolation can actually wear you down. And the contact was able to bring issues from the ground, and when people were reading experiences from their counterparts, whom they have never seen, and they were able to connect with them. And they said this was actually a hospital without walls. They have colleagues in a new world. And these were really coming out the very first publication of Contact. The other one, they talked about public health, and so many groundbreaking themes. What's the role of the hospital and the health of the community? Here they are looking at, okay, this is a big hospital. If you can split it down into several health centers, which one is more effective between these two? Okay, we have a big hospital for doctors, maybe. The small hospitals are there for the people. Is health a profession, or health is a service we want to give to make to the people? A very groundbreaking publication, Primary Healthcare and the Village Health Worker. The Village Health Worker was the heart of PHC. And this language you see in the mid-1970s were already in the mainline discussions of CMC. Healthcare for all. These are the themes which were later refined to health for all by the year 2000. Community participation. Later it changed a bit its face. But we're extremely pleased now that we have an anniversary edition of Contact, where we have revised some of the seminal publications and reflected on them and say, okay, 40 years down the road, 50 years, what do they mean now? Within this decade also, before I close, was the signing of a memorandum of understanding between the World Council of Churches and the World Health Organization. The idea was that the World Health Organization says, yeah, the way you are bringing this evidence from the ground, yes, thank you, but we don't work that way. We have our own procedures. It's okay, so let's formalize it so that whatever you're bringing to the table, it may have a proper formal channel into the World Health Organization mechanism. And this was actually, it paved the way for primary health care to come into the mainstream discussions of the World Health Organization until 1977, when the World Health Assembly adopted primary health care. And after the PHC was adopted, then they started preparing for the conference in Alma Ata in 1978. Some of the critical pieces of work which were done, as we said, were the country visits, country support visits. They were very prolific. There was the visit to Botswana. This was the visit to Nicaragua, Bolivia, Brazil. This was Ghana. This one was Sierra Leone. Another visit to Ghana. This was to Greece. This was Liberia, Southern Sudan, Tanzania. This was Nepal. This was a visit to Zimbabwe. This one, Niger. So on and on, the Commission was extremely busy giving in-country support and bringing these experiences to the national, to the global platform. Now, after Alma Ata, now we look at the first decade. The first thing which quickly comes to mind was the resonance. The ecumenical fraternity, as the main protagonists of primary health care, devoted themselves fully to PHC, as Ben has already alluded to. After all, it was born out of intense interrogation of medical theological understanding of health and healing. And so it really resonated with the ecumenical fraternity. And then also we see a public engagement, stepping on the public space. Something which started in 1974, a bit of, I put it in quotes, a war on baby milk substitutes. Now, after 78, you see these boycotts continuing, but the church is taking a public stand, taking a public position on a public health issue. The other development is actually working on access to medicines in search for an innovative and to get collaboration. CMC started the Pharmaceutical Action Group in 1981. It promoted food procurement, supported development of international guidelines, helped the establishment of drug supply organizations like the Joint Medical Stores in Uganda, the Missions for Essential Drugs and Supplies in Kenya. The Pharmaceutical Action Group has now grown into what is called the Ecumenical Pharmaceutical Network. But immediately after Alma Ata, there were a couple of setbacks. The first setback was already alluded to, was the conference that was actually took place only 1 year after Alma Ata, 1978, where now selective primary health care came on. And UNICEF, World Bank, Rockefeller Foundation, Canada, the USA, and others were on board the new wave of selective primary health care. And this change in position by major financial players led to sustained reduced funding to the health sector in many developing countries, especially under the World Bank IMF Structural Adjustment Program. Also, as the Cold War raged on, global military spending kept on increasing, and health spending suffered. And the coming of HIV on the medical scene also made matters worse. Some of these are the publications we referred to, the World Health Organization, the CMC's involvement in the PHC, and also the origins of selective primary health care. So these are published reports. And then we see that within that decade also, the church's response to HIV was a quick adaptation of PHC, where churches immediately started the community-based, home-based care programs for HIV. Even though we started off on a wrong foot in terms of the theological, the moralization of health, but we see that actually over time we have come of age, and churches have ended up being key players in treatment, control, and prevention of HIV and AIDS. I mentioned about studying. So there was continuing search for a biblical understanding of health and healing. And there were 10 consultations in that decade, and those have been published in that report, which are very systematic and rigorous reports across the different regions. And there were 10 different consultations which dissected the feelings on the ground, the experiences on the ground. What does health and healing mean to the churches and their communities? Now, church health institutions continue to collaborate with governments, and they participated, of course, in the Millennium Development Goals, and now we are in the era of the Sustainable Development Goals. We have seen increased collaboration between governments and church structures, like provision of health worker salaries, service agreements to offset medical and operational expenses, also channeling of donor funds for development and service delivery, technical and financial support for training institutions, and many other forms of collaboration partnerships on the ground. But what has changed? To varying degrees, I think the collaboration has become co-optation, and the assistance has become a tool for assimilation. Nowadays, one has to hunt for the distinctive feature of a church hospital. Whereas in 1964, they worried that the medical institutions and the churches had traveled in different directions, I think the worry is I don't know, 100 times worse. Many church hospitals, CHAs, and others, they don't see themselves as an arm of the church anymore. Apart from the name, many are all too happy to operate as an NGO with no business whatsoever with the churches. Also, we see that now we have weak theological grounding to anchor our approach to our work. And the cooptation and the assimilation has actually limited the innovation. The terms health and wholeness, healing, holistic health, they are really not a part of our language anymore. So in conclusion, I think the key observations which I can make is that there was a very strong ecumenical collaboration along these years. And we see when this ecumenical collaboration was strong, the achievements that were made, the strides that were taken. And there was also sustained medical theological inquiry. And the collaboration between WCC and WHO, we see the fruits that came out of it. My final thoughts would be now, what collaboration and networking do we need to reinvigorate primary health care and the dream of health for all within and beyond the Christian family? And the other question is, are we still capable of thinking outside the box? In our contemporary times now, and when we look at primary health care post-2018, there will be the commemoration in Kazakhstan, post-Astana. As the ecumenical family, are we able to think outside the box? The history has shown that we were actually able to think outside the box and bring those thoughts to the mainstream health sector, to the mainstream health conversations through meetings and publications. Do we still have the capacity to think outside the box, to bring the challenges of today and think and bring solutions to the table? My very final slide is actually a parable of the Good Samaritan, because it is very easy. The parable of the Good Samaritan resonates very well with medical missions. But a holistic approach to health demands that we consider all the characters in this parable, not only the Good Samaritan. We should consider the victim, the priest, the Levite, the Samaritan. We should also consider the innkeeper, the donkey, and the bandits, etc. Our role as Christian health workers is not only that of the Good Samaritan. Sometimes we are the innkeeper. Sometimes we are the donkey. Hopefully we are never the priest and never the bandit. Sometimes we have to look beyond this parable and analyze root causes of suffering and challenge systems and structures of injustice at all levels. Who is not in the parable? Who is not mentioned in the parable? We need to be responsible, visionary, and transparent innkeepers. We need to be informed, courageous, and strategic advocates against systems and structures that militate against holistic health. Health for all must be a reality in our lifetime. Thank you.
Thank you very much, Moy. I think it's been a very powerful discourse, and I think you brought out a very fundamental issue of all of us being able to think outside the box. Ben looked at looked a little bit historically from outside, but you also looked historically within WCC inside. And as a good physician, you took also a great history and made a lot of diagnosis of the symptoms and signs, and also looked at the potential prescription very comprehensively from the actual rethinking on the medical theology, which started taking place in the 60s. And then also the formation of the Christian Medical Commission, and then the National Ecumenical Health Associations, and the healing power of everybody working together, the healing power of working with the community, the congregation's responsibility. I think those are the fundamentals of primary health care as well as development. You also brought out something on the importance of communication, the contact, a very powerful communication tool. And also the visits to the field to see reality, because sometimes we can forget reality in the capital cities and even in beautiful places like Geneva. I think that was also very much emphasized. And I think you have again brought us back to the point of from the past to the future at this historical movement in both the World Council of Churches and WHO at 70 years, and also the rethinking of primary health care anniversary. Right, now I think we can now move to all of you here. You have heard the speakers. I will say a few words about myself. I'm a clinical and public health medicine specialist. As you can see, a young veteran of different levels of the national health services and health systems of Zimbabwe, Southern Africa, and different levels of international WHO. I have tried to keep a focus on integrated and comprehensive clinical and public health service delivery, and as you heard, the balances between vertical, priority public health programs and horizontal national health services systems. As a young doctor in a remote mission hospital in Zimbabwe in the early 1980s, with no access to internet and social media, when Moy mentioned isolation, my very important reading, which I always used to wait for, is this. That used to come regularly. So this was what I now go back to. This was so valuable. It showed what was happening elsewhere. It built you into the community. The other thing which I also received was from WHO. It was on World Health. It was a general public health. Oh, right. Thank you. World Health. And one of the things which we all worked in those days, and this one is titled In Service of Health. And that's a very important fact, the service of health. So even today, many of the remote mission hospitals and even government hospitals value the communication, even though we might have periodic and fragile internet access. So I think that's the reality which we have to work with as we go out there. So please, I think you have heard a very, very rich discourse, which I haven't heard for a very, very long time, from both Ben and Mwai. Now we would take some thoughts, suggestions, and the purpose of the Global Health History Seminars is to go from the past to the future. Learn and understand what happened before as we move and actually mobilize for the future. So we hope that some of you will commit to this network as we mobilize to actually, as Mwai said, promote the work of the church in health, and also the collaboration between the church and faith-based organizations and WHO and other organizations. We have seen many partnerships in Geneva, but how many partnerships are there in this very important aspect? I think it might be time to relook at it. The role of the Christian Medical Commission in the past, and again also look at the role of reaching out. And it's very nice to hear that the contact and anniversary issue will be produced today. Right. Any thoughts, any suggestions, any ideas? You all look very serious.
Yes, thank you very much. I am Peter Boa, the Executive Director of CHAG and also the Chairman of ACHAP, African Christian Health Association Platform. Thank you so much for the insightful elaboration, taking us back to history, and then the present, and then posing the question, can we think outside the box? Does the church have the capacity? The answer is emphatic yes. Probably let me cite two scenarios in terms of CHAG. Primary health care, when I joined CHAG from the district level in the 1990s, CHAG was the champion of primary health care. Abasi, Sunyani Diocese, and then Presbyterian hospitals, and then health system have several primary health cares to date. What happened? These health facilities or primary health care interventions were later assimilated into the system, and then the rest is history. Some of them are still struggling. Now, the second innovative intervention that the church made in Ghana was the National Health Insurance Scheme that we all have. It was a church that recognized that we had financial barrier. The catastrophic cost of healthcare was a barrier to access to health service. So the church pioneered and piloted 40 community-based health insurance schemes in the 1990s. It was by CHAG, first by the Catholic Church, and then CHAG established 40 of them. These were nationalized in 2004 by the government to form what we now have, the National Health Insurance Scheme. Now, suddenly, the church is struggling to find a place in the National Health Insurance Scheme. So our capacity to innovate and come out with interventions that are very impactful at scale is there. But perhaps our biggest challenge is our inability to have that stewardship role, to own our innovations, document them, and ensure that we scale them at large. So we have the capacity to innovate because we are Christians, so we are inspired by the gospel. See, I make everything new. So our ability to innovate is clear, but our capacity to consolidate our innovations, own them, and then spread the gospel of change is our biggest challenge. Now, as I speak now, the church hospitals in Ghana are so assimilated. There's this loss of identity, just to validate what my brother Mwai said. So how can we innovate out of the box? We were co-creators of primary health care, but then suddenly we are now struggling to find a place even in Astana, I believe so. Where is our voice? CHAG was key creator of the National Health Insurance Scheme, but then suddenly it's been taken over by government. How do we consolidate our innovation so that it will be a perpetual gospel for us? That is a thought that is it. So the answer is yes, we can innovate. Do we have the stewardship capacity? I think we must build the capability system for that. Thank you very much.
Thank you very much. We'll take a few more inputs and comments. The gospel of change, the problem of assimilation, and then still being left behind, whether we are there as part of the World Health Assembly or others. This is a very important issue. Yes, please. Next. Thank you.
Thank you. I'm Nyabura, and I am coordinating ecumenical HIV and AIDS initiatives and advocacy, which has benefited a lot from WCC having a program on health and healing. But because within that context, we have a crisis of faith healing alone, particularly in the subcontinent of sub-Saharan Africa. But I know it's not limited to that. But I know that this is not a problem that has come up with HIV. It's something that we have had for a long time, and I know that WCC has addressed it once in a while. And really what I remember vividly is when I was in the 80s, when I lost a cousin whom we had grown up together in the village, who got malaria. And because he had joined a church that doesn't allow its parishioners to go to hospital, we lost him because he couldn't be treated even by whatever. I mean, so I'm just trying to say it's not a new problem, but my question is, how can we access facilities for researching this area of crisis? Because this is something that churches have to do themselves, because this is something we create. The faith healing is one of the theological aspects probably we have not been very consistent about. So my question is, how do we get the facility to really understand and research and come up with studies that will help us to have solutions to the problem? And thinking of this, I am also looking at my brother from Zimbabwe, because I know there is a very particular church, the Apostolics. Part of it is one which is well known not to practice medicine at all. Even for delivery of babies, they ensure that the attendants are the senior mothers who may not even have the skills. So it's really becoming a crisis, at least in sub-Saharan Africa, but I'm sure it's not limited.
Thank you. Very important point on faith and healing. Not only in HIV, I think we have a lot of lessons originally from leprosy and TB, and now HIV, and then the denials, not only on HIV, but also on even immunization.
Manoj Kurian, coordinating the WCC Ecumenical Advocacy Alliance. Thank you very much for the excellent input. I just wanted your thoughts on, especially on the issue of privatization and the withdrawal of government from healthcare. And in this whole challenging context where healthcare is becoming more expensive, but government seems to be retreating from their responsibility to provide health. And what do you think faith communities can do, church health services can do in this context? Thank you.
Last intervention.
Yes.
The issue of privatization and governments and all withdrawing. Even the church has a private arm as well. Sorry, yeah, the church is also has a private arm, although governments are also withdrawing, and sometimes the church is also withdrawing from healthcare. Yes.
Yes, thank you very much for all your questions and your very interesting contributions and your comments. So I'm here from the University of Zurich, and we have a team there at the Faculty of Theology, which is studying the introduction of religious concept of health into the WHO. And as you may know, in 83, 84, there was a discussion in WHO to expand the definition of health to include a spiritual well-being. And in 98, again, that came up, but not much has came out of it. And so a lot of the things that I've heard from the participants here is exactly the problem of co-optation and losing touch. At this integration into the WHO and these global systems come at a big cost. And so the attempt to integrate something into the WHO to expand the definition of health in turn, I think could be a way to maintain that what you really care about when you work with these biomedical institutions. So yeah, my question to you is really, what has happened to this attempt to integrate religious aspect of health into the WHO since 98? Thank you.
Thank you very much. Is WHO a public health institution, a biomedical institution, a religious institution? Those are very important questions you have brought up, and I think we need to look at. And again, the same theme, the church innovates, the church teaches. How do we bring the teaching to bear in even the performance of WHO and the work of WHO? Now I'll hand off it to both speakers if they can comment on these three issues which have come up: faith healing, the work of religion and theology in health, and in the work of WHO, and more important is also how to maintain the distinctness and the position of the church and faith-based organizations within national governments as well as international organizations.
There's a lot of fascinating topics that I think are emerging here, but let me just deal with one before I pass on to Mwai. Your point about faith healing reminds me of the smallpox control and eradication program in West Africa, and the difference between Frank Grant and Bill Foege. So Bill Foege was in Nigeria, and there was one particular church that he writes about when he was trying to eradicate smallpox that wouldn't have any immunization and shut him out completely. And I think the result was that there was a lot of them contracting it until the point in which I think they potentially had to recognise there was an issue. However, in contrast, Frank Grant, who is the leader of the smallpox eradication program in Ghana, was the son of the head of the Methodist Church. And I was speaking to his now sadly deceased wife, Mary Grant, a couple of years back, and she was saying how when Frank went to communities, they would trust him because they understood his shared faith. And I think perhaps the answer is not to say, oh, well, we have to fight faith healing, or faith healing needs to do this or that or the other. I think it's more basic that if we can build trust with communities, it doesn't matter if we disagree or if international health organizations disagree on some fundamentals. Over the long term, relationships will be built that actually have health outcomes. I think that's probably, pass over to Mwai if you've got any particular comment.
Okay, yeah, I will talk about the privatization and government withdrawal. In this new edition of Contact, we've talked a bit about our feeling that health is a human right. Okay, from 1948, health is a human right, but also as WCC, we believe that health is also a matter of justice. It's not just a human right. So if we pursue health only as a human right, we know that there are so many human rights which are denied many people. And people are every day advocating for the rights of X, the rights of Y, different groups, either age groups or ethnic groups. But healthcare is actually a matter of justice. So if governments are putting in place situations where some parts of the population cannot have good health, it is an injustice. It is an act of injustice. It's not just a simple act of omission. Or we omitted to put up a clinic. It is an active injustice. And perpetrating situations where people cannot enjoy their full health, either directly or some indirect causation, those are all acts of injustice. That's why you see that in the 1970s, when civil society groups started protesting against unethical marketing of breast milk substitutes. In 1980, churches came on board because it was not just a matter of human rights, it was an injustice for companies to make profits out of ill health. It is an act of injustice for people to make money out of health, to make names out of health. So the health profession, I think in a way, has become a huge business empire. And the medical profession itself is now a tool of oppression, where we have a select few that are advantaged. And so I think the withdrawal of governments, when governments withdraw, who comes in? is because when one partner retreats, another partner comes in who makes money out of it. And we don't know who influences the other to retreat. Would it be that government's actually retreating because they are being influenced by those who say, okay, if you retreat, we'll come in and we'll make money out of your retreat. And we'll give you these advantages, these benefits, to induce governments to retreat. Okay, so government should not, ABC should not run this type of programs. Oh yeah, supply chain of medications we have to privatize. Let's give it to a private entity. Oh yeah, procurement of this, let's give it to a private entity so that governments can only concern themselves with the business of running government. And so we see that bits and pieces of critical care services have been split and outsourced. I think it is an act of injustice.
The last 2 points on the how to maintain the distinctness of the church and how do you bring religion back into the mainstream. In some cases it has been neglected or even avoided.
Yeah. I agree with both, and I think part of what I think is the questions which are raised. Can we maintain networks? Can we work together afresh? Because sometimes we are fighting big battles, and when you are fighting them alone, you cannot really make progress. So you become a lone voice, and so can we work together? And if we work together, we have the other issue which Peter mentioned about documentation. How can we document our experiences and bring those experiences into the mainstream conversations? Now, if you're writing your own little story in your small corner, another one their little story, and you are not networking, okay, so we need to network and document and share practices and see how can we, first of all, internally share our experiences and improve our practices. Because when we see what was happening historically, CMC and the others were not bringing a half-baked proposal to the table. They were bringing proposals which they were tried and tested, and there was evidence. And up until we are able to bring that quality of evidence, otherwise we just embarrass ourselves.
Thank you very much. Any last points?
I would say as well that part of the answer to some of these questions is more sessions like this where we come together to both promote the significance of what's happened in the past, the innovation that has gone on in faith-based organisations, and also to discuss new ideas and to discuss new collaborations with the kind of exciting work that Mwai and Shiva are doing. Hopefully that what this will be is the start of something rather than just a summary of it.
Thank you very much. Last quick one, please.
Sorry, I don't have an intention to take anybody's place. I'm visiting from the WHO Health Workforce Department, and I just wanted to, I loved the reflection, in fact, about the communities and faith healing, because a lot of the learning that we've done for Ebola, for example, has really come with the traditional healers, the faith healers, the religious leaders, who are the key to getting to a community to bring evidence-based solutions to them and modify practices. I worked in Sierra Leone in the last outbreak. Specifically, though, what I'd like to invite is collaboration. We will, at Astana, be coming out with community health worker guidelines, which I think, I hope you will appreciate as community-based, looking at how to extend health services for all, looking how to have a rights-based approach to community health workers so that they are indeed part of the health system. We recognize that those workers are representatives of NGOs, of church missions, of communities specifically. And what we would like to do is invite your collaboration in helping these guidelines to be introduced to governments, to be adopted, and to be recognized, so that we are in fact reflecting the community that you all are such an engaged part of in how we promote evidence-based health standards. I see this as part of a big organism, not somebody being more important than another, but all of us have a role in promoting primary health care and in gaining health for all. So I hope you will you'll join us in taking a look at these guidelines and seeing where we can extend health for all to communities who really need it.
Thank you very much. When you talk about the community and the community workers of different types, from the congregation to everybody, that's where it starts. And I think this is definitely a long-term collaboration which we'll take with all aspects. But as Ben said, this is the start of a movement, a discussion, and from the rich presentation, I'm sure that such a presentation within WHO also is very critical, because WHO is in the movement of change as well. And again, taking primary health care forward is very important. And I think we should consider taking, and I'm sure Kingsley is also here and others, that we should reach out and maybe continue the discussion and debates both within the WHO. In Astana, there'll be a session as well, which we hope we can also continue the discussion. But more important, as was brought up with by Peter, is we have to practically do it. How do you expand the community health workers in Ghana? How do you expand the church in Ghana in a distinctive way, and is recognized as a very important? I would like to now close to thank our colleague there who has helped us with the communications and has been vital. We'll be all on podcast, and I want to also thank all of you who have made the time, and many of you can also link up and put your names down as we take this movement forward. Thank you very much, and have a good day.